So good. Okay. I hope you're able to see the screen at this point in time.
Yes.
Yeah.
You are. Okay, great. And I've got to put this into presentation mode, and then we're gonna go. We're gonna be good. We're gonna be good. So, all right. So I'm thinking you're seeing right now my first slide, which features Jan Gosta Waldenstrom. And, you know, I always like, whenever I give these talks, I always like to pay a little bit of tribute to Dr. Waldenstrom, because when he described this disease, it was at the height of World War II. You know, he sent this manuscript off to a very prominent Swedish journal, and no one really believed him. They all thought that he was just describing cases of multiple myeloma. So he had a really hard time getting that paper published, as his son would then, you know, relay to me. And it took almost 15 years after he published this paper describing a few cases of Waldenstrom, or what we know today as Waldenstrom's macroglobulinemia, to then have other papers confirming his observations. And of course, we all know today, and I'll show you more data, that he was spot on in terms of describing a new disease. Just a reminder to everyone on this call that Waldenstrom's can present very differently. And as a result, sometimes we have to customize our therapy. Most people with Waldenstrom's, the disease is found in the bone marrow, and this can cause anemia. It can cause the platelets to go down and result in increased risk of bleeding. It can cause the white blood count to go down and put the patients at increased risk of infection. But a lot of the action of Waldenstrom's is mediated by the IgM that's made by the Waldenstrom cells themselves. And that IgM can sometimes affect the viscosity of the blood. If it makes the viscosity very high, you can get what we call epistaxis, nosebleeds, headaches. You can have problems with vision, and you'll see in just a second why. Sometimes the IgM turns on the body itself. It can attack the red blood cells. We call this cold agglutinemia because it's under colder conditions, the IgM binds to red blood cells and destroys them. I'll show you a very impressive picture of what we call cryoglobulinemia. And we can relate to this because we're in the colder parts of, you know, the world here, especially in winter. So under cold conditions, the IgM falls out of solution, much like, you know, salt. If you put too much salt or sugar in water, you see it falling out of solution. Well, the cold can make that happen, and the IgM can fall out of solution and block blood vessels. In many patients, the IgM can attack nerves. I'm going to show you a picture in just a second, leading to neuropathy. And nowadays, actually, a lot of our referrals come from neurologists. So almost a quarter of the patients presenting today come in with a type of neuropathy. I think whoever has not unmuted or muted should probably do so, because there's a lot of background noise. It might be good for everyone to mute if possible. Now, enlarged lymph nodes can be seen in about 20% or less patients at diagnosis. By relapse, meaning when, you know, the disease is more advanced, it's far more common. And then Bing-Neill syndrome is when the disease gets into the brain. This used to be very, very rare. Now we're seeing more of these cases because as patients are living longer, this is becoming a site where disease can find itself. Now, why I show you this? Because many times patients present very differently. And as a result, you have to customize your therapy around the way the patient presents. And so I just want to emphasize that, because, you know, you might custom tailor the therapy based on how a patient is coming in to see you. I always like showing these pictures because they tell you what are some of the things that we see when patients come in. This is somebody with very bad hyperviscosity syndrome. You should always do an eye exam. If the IgM is above 30 or 3,000 milligrams per deciliter, you should be getting regular eye exams, preferably by an ophthalmologist, because they can dilate the eye and look. And I'm going to show you why that's important. When you dilate the eye, you can see a lot more features. Here's somebody with sausaging. You see these very tortuous blood vessels. This is because, there's a lot of, the viscosity is very high because this patient has a very high IgM. And look why you have to dilate the eye. Look at all these hemorrhages. These are all little hemorrhages from the blood vessels breaking under all that force, that viscosity force. And if you come in to see me, I can't dilate your eye. It's not something that we do in our clinic or most clinics and from oncology or hematology practices. So you might miss these things, which is why you really want to get a good, eye exam. Here's somebody with very, very bad cryoglobulins. As I mentioned, under cold conditions, the IgM precipitates. It's usually the colder parts of the body, and as a result, the blood flow is restricted. And this patient underwent a procedure called pheresis, which is like a dialysis procedure, clearing the IgM and restoring the blood flow. Now, I mentioned neuropathy. So under, for a lot of patients, the IgM binds to the sheath, the insulation around the nerves. These are from a biopsy sample where the material was cut across, the nerve was cut across. There's the nerve in the middle. This is the sheath around the nerve. And what you see here is the IgM binding to that sheath, that myelin sheath, and destroying it. And so this accounts for a lot of the patients coming in. Usually the neuropathy is numbness, tingling in the feet. It starts crawling up. And then somewhere between the sock line and the knee, it skips and then starts involving the fingertips. And if you don't treat this, over time, patients can lose sensation and have trouble walking, driving their car, even walking down steps, buttoning their buttons. So this is something that we try to get into treating earlier than later before the nerve destruction happens. This slide is supposed to remind all of us that there are guidelines out there about when it's appropriate to treat a patient and when it's appropriate to watch and wait. So if you're, very anemic or have symptomatic hyperviscosity or moderate to severe neuropathy, or these cryoglobulins that are symptomatic or cold agglutinins that destroy the red blood cells, fair game to treat. But a lot of patients, it's okay to also watch and wait. Now, one of the areas of contention is, what do you do with somebody who has a very high IgM but has no symptoms? They're rare, but they happen. We tend to treat if the IgM is above 60 or 6,000 milligrams per deciliter, because the risk of having an event associated with hyperviscosity is way too high. So you'll see in our practice, based on data that we've published, that we treat. We don't just sit around until somebody loses their vision as their first presenting symptom. Now, traditionally, we've treated the disease with Rituximab either alone or with other drugs. Now, the reason why this is important for you to know is that when you use Rituxan by itself, maybe 25, maybe 30, maybe 40% of the patients will respond. You never get complete responses, and the benefit lasts for about 1.5 years on average, which is why we've combined, Rituxan with many different drugs. But the ones we tend to use more commonly today are the proteasome inhibitors, like bortezomib, or the drug bendamustine. I know you're all familiar with these drugs, but you see the difference. You go from 25 to 40% of patients benefiting up to 90%. We don't really get many people in complete remissions, even with this intervention. We can get the disease down even further than Rituxan. And that's enough to get us benefit, where we can suppress the disease for about 4 to 6 years on average in the frontline setting. So I think it's really important to just keep in mind that combination therapy is preferable to Rituxan just because we can get more mileage with it. Now, unfortunately, there are complications with all these drugs. Rituxan can cause the flare where the IgM goes up. IgM goes up, it can cause a lot of problems. It can cause hyperviscosity, it can cause the neuropathies to get worse. Fludarabine and bendamustine, we worry about secondary malignancies, although the risk with bendamustine is 5% of a second malignancy. With fludarabine, it's about 15%. we tend to use less bendamustine today. We used to do 6 cycles, now we do 4, just to decrease that risk even further. And with bortezomib, we see a lot of neuropathy, which is why it was very important to try to improve therapy for disease by better understanding.
Can I have my wine and we'll hold on a little while because it's such a good thing to hear him again.
Can people mute themselves, please?
Whoever just said that, thank you. I hope you're referring to me. But you may want to mute. You may want to mute.
Not you, Dr. Treon.
For your own benefit. All right. So here we go. This is the important slide because this is the change, in an era, and that's whole genome sequencing. And whoever mentioned earlier, I think it was Betty McPhee, mentioned Peter Bing. This is Peter Bing, a wonderful philanthropist who has, given generously to the Waldenstrom cause. He himself is a patient, but what he did for Waldenstrom's is amazing. So he invested in what we call whole genome sequencing. It was at the beginning of when genomic sequencing was possible, that we could actually take a cell apart and understand all the DNA molecules in it and how they were behaving. And this effort was published in the New England Journal of Medicine, involved 30 Waldenstrom patients who gave us their Waldenstrom cells. And here we discovered that MYD88 mutation. I'm going to tell you more about what that means in just a second. Soon thereafter, Zach Hunter in our laboratory used the same data, but he's a computational scientist. So he actually changed all the algorithms. And he was able, because of that, to discover CXCR4. This is a mutation which affects about 40% of patients, whereas the MYD88 mutation affects about 95%. So all of a sudden, we were privileged to have 2 highly, expressed mutations. And I got to say, this is luck, because most diseases, most cancers, you never find this kind of redundancy in the same mutations. Like in myeloma, the highest recurring mutation occurs in 4% of patients. So to find something, at 95% for MYD88 or 40% for CXCR4, truly, truly amazing. Now, I just want to say that I'm going to go right to this slide here, because I want to talk a little bit about what this mutation meant. This mutation allowed us to understand why Waldenstrom cells grow. Look at this molecule called NF-kappa B right at the bottom here. This is actually bad news. Whenever it's turned on, it means the cell is growing and it doesn't want to die. So what's right above NF-kappa B? You have MYD88. MYD88 normally is in the circuit of these receptors or antennas that receive signals when bacteria or viruses, even the coronavirus, binds to the toll receptor. And that's how the immune cells know something has gone wrong. And it fires up the cell to grow and survive. And it does so through MYD88. But in our laboratory, we discovered that BTK, Bruton's tyrosine kinase, was actually part of this complex. This is what gave us the chance to look at ibrutinib as an important new drug. And not only that, but we discovered, because of, again, funding and support by Waldenstrom's, Canada, the IWMF, the LLS gave us the funding to do this. We also discovered HCK was another molecule that was actually turned on. And this is what actually turns on BTK, as well as all these other molecules that help the cell grow and survive. And what we also found is that ibrutinib also shuts down HCK. It's actually a very interesting molecule. It has a lot of similarities to BTK, but you actually have a twofer here. And we'll also be talking about the drug zanubrutinib very shortly. It does also the same thing. It also tackles both of these very important targets. CXCR4 is a very interesting molecule. It's also a receptor and antenna. It signals for these molecules called CXCL12. They're made in the bone marrow by these cells called the bone marrow stroma. And when these molecules come in contact with CXCR4, they can actually turn on circuits that lead to drug resistance. And the problem is that when you get the mutation in CXCR4, this antenna stays on the on position and continues to signal for CXCL12. So when you think about, MYD88, think about the fact that it's turning on the Waldenstrom cells to grow and survive. When you think about CXCR4, think about the fact that it's turning on pathways that are important
now that I don't
for
know.
affecting drug resistance. So that's why, as we go through the data in just a second, you'll realize
I don't know.
why these, mutations play different roles.
My mic's off, but some people don't have their mics on. Like you see it pop up, the people.
Okay, you can't get a bigger screen on them, or can you?
If
Or you-
your phone number starts with 774, we're talking to you.
Okay, so I want to update you on the ibrutinib trial.
And don't have their mics off. He's a speaker, but there's other people that don't have their people.
Well, there-
People know how to turn them off.
Yeah, that might be
Look at
the
the
real
top
issue.
and it says mute.
This is what we're showing. This is the display. When he just talks to see, his
Okay.
picture comes there.
So how long is the one for?
Oh, probably not much. So I don't
Well,
know.
is there any way we could do the mute actually?
Do you want like supper?
Yeah, you can come
Do you
in
want
anytime. I can eat it right here.
Bob Gary's mute yourself.
Oh, I'm sorry. All I
No, I don't blame anyone. Finding all these
Oh, there it
buttons is not easy.
Well,
And
we're all
iPad.
older.
Sorry, I just want to really make clear that you have to mute. It will be on the recording, so please mute
Yeah.
please mute.
Yeah.
Thank you.
Thank you, Betty. Okay, I just want to show you the data that we just published in the most prestigious Journal of Oncology, Journal of Clinical Oncology. This is the long-term results of the ibrutinib trial in people that were previously treated. For starters, these were very sick patients. They had on average 2 prior therapies, and some had 9 prior therapies, and 40% were refractory or resistant to their previous therapy. Very, very sick population of patients. But look at the overall response rate, 90%. Major response rate means at least 50% of the disease went down, almost 80%. VGPR, meaning that 90% disease reduction, 30% with the long-term follow-up. But now let's look at how these patients behave depending on their mutation status. So if you had no mutation in MYD88, we call that wild type, WT. No one really responded. They didn't get those deep responses. If they had the MYD88 mutation alone, look at these response rates. Major response rate, 97%. Almost half had a VGPR. If they had both mutations, you see that there was a decrease in those in the major response, and even a bigger decrease in very good partial response. And it also took longer. It took about 5 months compared to 2 months to get to a major response. So you can see that, we learn a lot from knowing what somebody's MYD88 and CXCR4 mutation status entails. Now, I'm going to show you also the data, which I think is also very important to share, and that's how long this benefit lasted. With 5 years follow-up, 54% of the patients still remain on their ibrutinib. And at 5 years, 87% of the patients are alive. Now, again, very sick patients, coming into the trial. This is actually really good news. So we learned also that depending on the MYD88 and CXCR4 mutation status, the benefit was different. So if you only had the MYD88 mutation, 75% were, without the disease progressing at 5 years. If they had both, it was about 35%. And if they had no MYD88 mutation, you see they actually progress very, very quickly. So this is why having these, knowing these mutations, the MYD88 and CXCR4, are very important. Now, what we learned in this trial was that with the long-term follow-up, we had more atrial fibrillation. So when we first reported the study in the New England Journal, about 5% of the patients had atrial fibrillation. It included also things like grade 1, which is even some minor palpitations. So I don't want you to necessarily panic at this number, because it can involve also very modest palpitations. But the news is that at 5 years, it was almost 13%, but most of these patients continued on their therapy with medical management. So it didn't alter the management for 7 out of the 8 patients. So I think that's really important to also keep in mind. Now, there's a big study that actually occurred after ours. It started after ours, called the Innovate Study. This was an interesting study. It took place in 9 countries. Canada, I believe, was also part of this. And patients got ibrutinib and Rituxan or a placebo and Rituxan. And it was really meant to be a regulatory trial to prove to the various health authorities that ibrutinib was better than Rituxan by itself. And so what we learned in this trial was indeed patients who got ibrutinib and Rituxan had a much higher response rate, even those major responses, than Rituxan alone. But again, when you look at how the patients did based on their genome, there were some differences. If you had the CXCR4 mutation in addition to MYD88, those major response rates were fewer. And it also, but in this case, the time to get to a major response was very similar. So the Rituxan added something. It added the ability to get to a response sooner, but the CXCR4 still kept those numbers down. And this is what we call progression-free survival analysis, looking at how long the benefit of the ibrutinib lasted. And you see the people that have the CXCR4, they actually progress sooner among the ibrutinib-treated patients. And so this, again, confirms the fact that we have a CXCR4 issue that we need to deal with. I'm going to show you in a minute how we're going to do that, but I want you to be aware of this. Now, the Rituxin Flare. I talked about it in the beginning. When you give Rituxan by itself, the IgM goes up. Sometimes it can cause a lot of trouble. In this study, they actually found that the flare rate was greatly suppressed if the patient got ibrutinib with the Rituxan. So if they got the Rituxan alone, half of them, just like our early study published in 2004, half of them got an IgM flare. But if they got Rituxan along with their ibrutinib, it was 8%. And this actually has to do with a very interesting mechanism that we described back in 2010. Dr. Guang Yang and our group described this. And he found that the Rituxan actually triggered cells, bystander cells, we call them monocytes, they're immune cells. It actually triggered those cells. It had nothing to do with Rituxan's effect directly on the tumor cells. It had to do with the fact that Rituxan was binding to these immune cells, causing this protein IL-6 to be released that then made the Waldenstrom cells make more IgM. And Dr. Yang showed that you could actually block that circuit. So that's why this was very nice to now see how the basic science data was giving us an explanation for why the Rituxan flare was blocked by ibrutinib in this study. Now, this is a slide I'm very, very proud of. It used to be very difficult to treat people who had Bing-Neill syndrome. This is when, again, the disease gets into the brain. This is probably one of our worst cases. This poor man went through so much therapy. This has been already published, this study. But, we were beginning to learn when we treated him with ibrutinib that ibrutinib actually gets into the brain. And he had one of the worst cases of Bing-Neill syndrome. You can see the tumor right there in the brain. You can see this whole yellow area here is tumor that's lighting up by PET CT. And so we treated him with a slightly higher dose of ibrutinib than we typically use, 560 milligrams once a day. It's the approved dose for mantle cell lymphoma. And within 4 months' time, look at the improvement in his MRI as well as in his PET scan. You see all that yellowish area begin to die out. And we also measured simultaneously the ibrutinib in his brain, in the cerebrospinal fluid, and showed that we were getting really good penetration, even at levels that could actually make a difference. So this is now, in our mind, the gold standard for treating patients who develop Bing-Neill syndrome is to give them ibrutinib, preferably at the higher dose of 560 milligrams once a day, although we also have some data to suggest that even the normal dose of 420 can be effective. These are kinome plots. What they're meant to do is to show you the differences between ibrutinib and the other new BTK inhibitors. And every blotch that you see means that it's suppressing not only BTK, but other proteins other kinases. And so ideally, the fewer blotches you have, the better, right? But in some cases, these blotches can actually shut down proteins that are important, like HCK, as I mentioned. And so to figure out if these different blotches or proteins being shut down make a drug different, you have to really do a clinical trial, because in some cases they can contribute to toxicity by shutting down more proteins that are important in other signaling pathways. In some cases it's good, it actually benefits the drug treatment. So I want to acquaint you with some new drugs like acalabrutinib, zanubrutinib, and tirabrutinib. I'm not going to talk too much about tirabrutinib because this drug is being developed almost exclusively in Japan. It's very, very active. The investigators presented their data at last year's American Society of Hematology meeting. I'm going to focus on acalabrutinib and zanubrutinib. So this year, earlier on, Roger Owen published the study with acalabrutinib in Lancet Hematology. First thing you need to know, acalabrutinib is given twice a day, whereas ibrutinib is given once a day. And this also was a study that had about a little over 2 years follow-up. The response rates, and I won't get into all these little bar graphs, were identical almost to ibrutinib. Slightly fewer responses with MYD88 wild-type patients, patients that had no MYD88 mutation, which is what we expected. And the duration of benefit was very similar in these patients. It included treatment-naive patients, so patients that never saw any previous therapy. It also included patients that were previously treated. There were some differences in the side effect profile. These patients in the first few weeks get headaches, and then eventually they tend to go away. They also do get atrial fibrillation, and at 2 years' time, it was about 5%. So a very similar incidence as what we saw with ibrutinib, and it didn't affect the patients continuing on therapy. Of course, we want to see longer follow-up to know that this rate of atrial fibrillation remains stable, in which case it might imply that it's better than what you see with ibrutinib. Now, the big news this year was the Aspen study. This was where zanubrutinib was compared to ibrutinib head-on. So the patients all had to have the MYD88 mutation to go on this trial. It was a big trial. It involved centers in Australia, Asia, as well as North America. The follow-up was very short, though, at the time of this report. It was about 20 months' time. And the patients were randomized 1-to-1. The patients that got zanubrutinib, the drug was actually given twice a day, 160 milligrams. They did an earlier study that showed that if they gave it once a day, they would have a fair amount of toxicity. So they settled in on 160, which gave a better safety profile. And the patients who got ibrutinib, they were getting it once a day. There was also this other cohort of patients who had no MYD88 mutation, and they got the same drug therapy, and there were some responses here, but I'm not going to focus on this because this trial has not been published. This one just got published in the journal Blood, actually just a few weeks ago. So this is why I want to focus on this, because there are critical details that we need to know about this study. So here are the results. What they saw was that the overall response rate between the two arms was the same, except that there were slightly more VGPRs, those very good partial responses. The major response rate was identical, but there were slightly more deeper responses associated with zanubrutinib. This, however, did not reach statistical significance. So this is going to be important to follow because these numbers might become different over time. Now, we don't know what VGPR means. I mean, if one arm has more VGPRs, does that mean, that these patients are going to have longer, duration of benefit? Are they going to have less problems associated with IgM? We don't know that, which is really critical data. And that's why we're going to have to wait longer to figure out what this Aspen trial result really means. They did do us a big favor, though. They ended up doing sequencing for CXCR4. And what they found was, just like we reported in the pivotal trial with ibrutinib, that the patients that had the CXCR4 mutation had fewer VGPRs than those patients that didn't. So both zanubrutinib and ibrutinib were affected by CXCR4. And I want to come back to this because I want you to know that we're doing things about CXCR4 in just a moment. Now, what was the big news out of this trial was the safety profile difference. There were fewer events of atrial fibrillation with zanubrutinib, fewer events of diarrhea, fewer events of bleeding, although these numbers aren't too much different. What was different with zanubrutinib was they had more neutropenia, the white blood count being low. In fact, in some cases, grade 3, you can see here 20% versus 8%. And at grade 3, we start worrying. If the white blood count is too low, it might put you at risk of infection, although they did not see in this trial an increased risk of infection, even though the white blood count was low. So there's a little bit of a yin and a yang here. And, we as clinicians, you as patients, we will have to sit down, whenever we're thinking about a BTK inhibitor and kind of assess, are you at risk for atrial fibrillation? Well, in that case, maybe zanubrutinib might be better. Are you at risk for bleeding? Maybe it's a little bit of a coin toss. There's not really much of a difference. Are you at risk because you've seen prior therapy of having your blood count, your white blood count, get too low and put you at risk of infection? In which case, you might decide that in favor of ibrutinib. But this is why you got to do randomized trials to figure out the good and the bad of each drug. I think this trial actually, quite honestly, I'm kind of optimistic because I think with longer follow-up, we may see even more meaningful results come out of this that may guide us, again, as clinicians and yourselves as patients to make a more informed choice. A few words about Venetoclax. I think that we can be all excited that this trial happened. It gives us yet another very important drug to treat Waldenstrom. This is a study that we've been running at Dana-Farber along with our colleagues at Cornell, John Allen and Rick Furman, and out in LA with Tanya Siddiqui. What did we learn? These were all previously treated patients. 90% overall response rate, major response rate 83%. So you can see it really made a difference, even in patients who had seen a BTK inhibitor beforehand. I mean, look at these major response rates, whether you had seen a ibrutinib or acalabrutinib before or not. And CXCR4 mutated patients did, just as well as those that didn't have the CXCR4 mutation. And the punchline here is look at the bone marrow involvement. It went from 40% before treatment. A year later, it was 3%. So it really has the ability to knock down disease, and it's able to keep patients in a long-term response. In fact, a year and a half later, 82% of the patients were still responding. This treatment was given for 2 years, and then everything was stopped, whereas ibrutinib was given continuously. And so it's important to keep in mind that this is now a new and active drug. We hope to have this paper submitted and published very shortly. But in the meantime, my good friend and colleague Jorge has already started a trial combining ibrutinib and Venetoclax in patients that haven't seen treatment previously. And this is also a definitive duration therapy. We're going to stop at 2 years, and then we're going to observe patients and see how they do. And so maybe this will give us the ability to use these drugs for a definitive duration of time. Now, I got to share some other very exciting news. I mentioned CXCR4. There are drugs that actually shut down CXCR4. One of these drugs is Ulocuplumab. It takes a while to get to learn how to pronounce it. It took me forever. But Ulocuplumab is an antibody that you give through the blood, much like Rituximab. It binds to CXCR4 and shuts it down. And we're doing this trial with patients that have the CXCR4 mutation, giving them Ulocuplumab and ibrutinib. The enrollment for this trial has ended, and it's a very positive trial. We were able to, see that patients who got Ulocuplumab, we were able to, make, their disease look like somebody who didn't have the CXCR4 mutation. So I think this gives us a lot of excitement going forward about targeting CXCR4. There is a new drug called Mova Rexophore. It's an oral drug which also shuts down CXCR4. So we're giving this now with ibrutinib in CXCR4 mutated patients. It's a very exciting trial. If you do require therapy and you have the CXCR4 mutation, I would tell you, please give a good look at this trial. because it has really a lot of good science built into it, and I think holds a lot of promise. So it's a trial worth considering. Now, I'm not going to spend a lot of time on this because I can provide this through Paul and through Betty to share with you. This is the paper that we published this year, where you can actually look at your genome, and there's recommendations on how to navigate through what treatment option you should consider, both in patients that have not previously seen therapy and in patients who have previously been treated. So rather than spending a lot of time tonight going through these blocks, I'd rather actually go on and talk a little bit about COVID. But I do want to tell you that we are now in the era where we can use the genome to help pilot how patients should be treated, both in the frontline setting as well as time when their disease may come back or if it hasn't responded to initial therapy. Let me go on and talk a little bit about COVID. This is a horrible pandemic, and as many of you know, one of the big problems associated with COVID-19 is that it causes pulmonary distress. And this can lead to patients becoming dependent on a mechanical ventilator and succumbing when mechanical ventilation doesn't help. And we were very keen very early on to see how our patients were doing who had become infected with COVID-19. And we were actually the first to publish this very important report. It made a lot of news headlines around the world. But what we saw was that when the patients were on ibrutinib, they actually did well with COVID-19. There was a lot of concern that maybe we were affecting their immunity and possibly compromising patients, who contracted COVID-19. Most of these patients were patients in the New York area at the height of the pandemic when it hit New York and the Northeast. And these are the cases here. This is a figure out of the paper. These are the first 5 patients were all on ibrutinib for quite some time. In fact, you can see the number of months here. The first 5 were on full dose ibrutinib. And despite contracting COVID-19, they had the cough and fever, but didn't have any shortness of breath, didn't require oxygen, and their course actually was relatively mild. Patient number 6 was interesting. This was a patient who was on low dose ibrutinib because he had a lot of muscle aches and weaknesses, And so his doctor felt that he might be at risk when he contracted COVID-19, and so held his therapy, and he became more and more short of breath. And, he ended up in the hospital. He was given several experimental therapies at the time. Mind you, this is still early in the pandemic, so hydrochloroquine and azithromycin, the antibiotic, were given. And despite this, his situation worsened. He couldn't really tolerate these therapies. He was given an IL-6 antibody and had some brief benefit, but then, he became more hypoxic, meaning he became more, short of breath, and his oxygen levels decreased. And he became intubated. And at this point, seeing how the other patients were, we advised that he go on ibrutinib at full dose. And when this happened, he began to improve very quickly. His oxygen status improved. A day later, he was off the ventilator. A day after that, he was off oxygen altogether and continues to do well on full dose ibrutinib. This made us look at the literature to learn and see, what mechanistically ibrutinib could have been doing to affect, lung function. And one of the things that, we know is that when infection comes along, it triggers those TLR receptors that I mentioned to you earlier that cause, the inflammation to take place in the lung. And this is where we thought, just like ibrutinib was shutting down the same pathway in Waldenstrom's, maybe this was exactly what it was doing in patients who contracted COVID-19. And so fortuitously, there was this paper that had been published 2 years earlier of a mouse model where the mice were actually infected with a very lethal strain of influenza, and they all died if they got infected. But if they had been given ibrutinib, they all lived. They had a brief period where their weight went down, but then it recovered, whereas the animals that were not getting the BTK inhibitor, they were getting saline, lost weight and died. And if you looked at the necropsies of these mice, the ones that were just getting saline were chock full, their lungs were chock full of immune cells, inflammatory cells, whereas a big difference on the animals that were getting ibrutinib, and all the cytokines, the proteins, the inflammatory things that cause this inflammation to take place, the inflammatory proteins, were reduced in the animals that were on ibrutinib. And so we thought maybe this was exactly what was going on in the patients who were, infected with COVID-19. And soon after our paper was published, about 2 months later, Janice Gabrilov in New York published this very interesting paper in CLL patients, alluding to the protective role of, once again, BTK inhibitors in patients who contracted COVID-19. And then came this very nice paper published in June by Mark Rachowski and our colleagues at NIH, once again confirming our observations, but this time with the BTK inhibitor Acalabrutinib. And so in response to this, we and others have started trials looking at the BTK inhibitors for COVID-19 patients. There are trials now with ibrutinib, Acalabrutinib, and we also have started a trial with zanubrutinib. And these trials are accruing, and hopefully we'll get some answers. And they're randomized, double-blind, so we don't know how patients are doing, until the study is completed. And so I just wanted to share with you how these kinds of observations, even in Waldenstrom patients, have triggered, global trials repurposing the knowledge and these drugs. In my last slides, I want to address some of the questions that I've seen in the chat box come up just a short while ago. Given the data that had been generated from these trials, a consensus panel was formed to try to answer some important questions around management of Waldenstrom patients, in this era of COVID-19. And so I'm going to just share with you the two very important questions. These recommendations were just published in the journal Hemisphere. Dipti Talalokar from Australia was the first author, but you will see that really it's a big list of international Waldenstrom experts that took part in this consensus panel. And the first one was, should we be changing indications for therapy in Waldenstrom patients? And what this was meant to say is, should we be doing things differently? It was recommended that if a patient didn't require immediate therapy, that one should, continue watch and wait. But if treatment was recommended, it then goes on to recommend that BTK inhibitors should be prioritized over chemoimmunotherapy, so Rituxan-based therapy, because the potential is that with Rituxan-based therapy, you may be suppressing, immune response. Now, mind you, and I have to stress this, we do not have actual clinical data to back this up. This is based on best guess from, experts that have been dealing with these drugs for very long periods of time. And so it's important to keep in mind that these recommendations are really meant to decrease the likelihood of suppressing somebody's immune system, putting that patient potentially at higher risk of COVID-19. However, in view of the early data with BTK inhibitors, prioritizing these over chemoimmunotherapy. And also the idea being that getting a BTK inhibitor is something you can do at home and minimize your potential exposure to COVID-19 while you are traveling or coming to the hospital. So that was actually part of this recommendation set. And with that, I'm going to stop at this point in time, and I'm very happy to answer questions. I think we have a little bit of time ahead of us, and my thanks again to both Paul and Betty for putting this together and for inviting me to speak with you this evening. Thank you.
Okay, Steve, or Dr. Treon, sorry. Should we just run through the chat? We've asked that anybody who wants to have a question has to put it on chat, and it has to be not a personal. We'll keep everybody on mute, and you and I'll do that, okay?
Okay, wonderful, wonderful, Paul. And I do see a fair amount of questions that are they're very similar, so that's going to help us here. So do you want to read the questions, Paul, and I can try to answer?
What can you do if smoldering phase to stop or slow progression in a younger patient?
Do we see that up here, Paul? Is it?
Well, I see it right at the very first question at the very top of it.
I am starting with from Gary to everyone. Is that the one?
That's from Kim.
Oh,
That's me. Hi.
okay. You know, Paul, I'm good. I don't see that question up here, but let me.
It may
might
not have
just
been
be.
sent to everybody, right? It might have just been sent to Paul.
Oh,
It was to everyone. It's to
Okay.
everyone.
Yeah, we don't see it.
Yeah.
Paul, let me let you read them out, and then I'll just answer.
Okay.
Well, can you answer that one, please? Because
Yeah,
I'm
let-
Kim. Nice
Hi.
to meet you.
Yeah. No, we're gonna let Paul ask that question again because I don't remember what he asked.
What can you do if in the smoldering phase to stop or slow progression in a younger patient?
Yeah, no, it's a good question. You know, at this point in time, we really don't have any, you know, any firm recommendations on how to slow progression. We have looked at this, and Kim, this was your question, right?
Correct.
Yeah, we have looked at this over time. You know, we did do trials based on some drugs that we saw early on were active, including Viagra. You know, we had a trial with Viagra. There was some activity for Viagra that was, you know, effective against Waldenstrom's. And we had actually one patient who had a remarkable response to Viagra. So we did the trial looking at, you know, patients with slowly progressing disease, see if we could, you know, impact with Viagra. We did one with simvastatin, you know, looking at a very similar approach. But none of these trials really had any enduring effect on decreasing, you know, disease progression. There have been trials looking at EGCG, which is a component of green tea in CLL patients. This is also a component that we saw, it has anti-Waldenstrom activity. But, you know, we have not had a trial to formally look at EGCG activity in this disease. So as of today, Kim, we do not have any, you know, drug that we're aware of that would be, you know, a drug that we would recommend for somebody who has slow, you know, moving disease.
Okay. And do you have any recommendations for a good doctor in Los Angeles
I
that
would say-
specializes in Waldenstrom's? I'm having a heck of a time. I mean, I've met some outstanding doctors, but they
Yeah.
just don't know the detailed information that you know.
Right.
And
Well, you know, there are several physicians who have a very strong interest in Waldenstrom's. Tanya Siddiqui is also part of our Waldenstrom's clinical trials group. She's based at City of Hope.
right.
So she's
Yeah.
just
I read
outside of,
her. Yeah.
yeah, she's just outside of LA. And Herb Eridat is based at UCLA. So those are the two individuals that have, you know, a particular interest in Waldenstrom's. And, you know, north of you is Ranjan Advani at Stanford, who a lot of our patients in California also go to.
Okay. Stanford. Okay. Yeah. I mean, I just found out I got diagnosed with Waldenstrom's like 7 months ago, and it's devastating. You know, everything that they didn't even know if I had Waldenstrom's. They thought I had mantle cell lymphoma, CLL. So it's been very upsetting, frustrating, you know, all the emotions that comes with everyone that's been, you know, newly diagnosed. And I just feel like people that are newly diagnosed, I don't know what's there for me. I know I appreciate the support group, but it's just so many unknowns for me right now. I'm still living in limbo.
Yeah. You know,
And you know, I don't want to have to have 2 little kids, and I don't want to have to go through that watch and waiting every month, every 3 months, it's just been very, very difficult for me.
Yeah. No, and usually for younger patients, that's exactly what it is. But
And
would
I have
recommend-
I have a large spleen, and 2 doctors told me to treat, 2 doctors told me to watch and wait.
Yeah.
But I feel fine.
So I, you know, since I can't give medical advice, you know, on
Yeah.
this broadcast. What I would say is
Yeah, and I'm
consider.
sorry.
Yeah, no, so it's totally okay. It's totally okay. I would recommend you connect with us. I mean, Jorge Castillo, who's our chief, we do consultations via telehealth everywhere, you know. So and you don't even have to come to Boston. So I think that's what I would recommend for you is to set up a formal consultation, and also recognize just from all the work we've talked today that you know, a lot is happening in this disease in a very positive way. So you know, I'm very excited about the future of this disease.
Do you think there's going to be a cure? Or because it sounds like
Oh,
I'll
yeah.
have to do chemo every 4 years. That's what it sounds like. Like I'm going to have to do chemo every 4 years.
Yeah, well,
I mean, from
again,
a patient standpoint.
Again, I wouldn't get into any specifics around your case, but do I believe there's a cure ahead? Yes, I absolutely do. I didn't believe that, you know, not too long ago, but the genomics now give us, you know, a lot of reason to be excited. And also just keep in mind, this is just the first chapter in a very long book. You know, there's all these other mutations that we're deciphering and other important pathways. I didn't get into them tonight because, you know, Paul only gave me 45 minutes here. And I've already chewed up, you know, way over that. But all I can tell you is a lot's happening, and all of you should be very proud because it's really a global effort on this disease. Paul, let me let you go on to the next question.
Okay, I'm just going to remind everybody that we're going to try and not get into our personal cases, and we'll try and if you want to contact Steve or Jorge afterwards, you certainly are free to do that. Just, it's a ground rule that's only fair to Dr. Treon to not put him on the spot. Okay, Ray wants to know, for a patient who had initial treatment protocol of Bena and Retuximab, and they had a very good response treatment, 6 to 7 years with no symptoms. When it comes time to treat again, what factors would you incline to treat with the same protocol versus leaning towards another treatment?
Yeah, no, that's a great question. You know, do we consider retreatment with bendamustine? And, you know, somebody who's had 7 years of benefit, I would certainly consider it. I'd want to know how that person's blood counts are doing, whether there's any evidence in the bone marrow of injury, you know, from bendamustine. It would be a consideration. I would look at the patient's age. The younger the patient is, the more adverse I am to using a drug like bendamustine because, you know, drugs like bendamustine belong in this class of drugs called the alkylators, and they could cause potentially injury to good stem cells and even, you know, trigger bone marrow failure or even leukemia. So it's really a case by case basis. But, you know, when you see somebody benefiting with a drug, you know, and got 6-7 years time, you certainly will put that on the list of drugs that you might, you know, consider when and if treatment is again necessary.
Okay, thank you. Are immunoglobulin numbers the main consideration before starting ibrutinib?
No, you know, and that's a good question, and I'm glad somebody asked it. You know, we don't treat people per se based on their IgM, except when it's over 6,000 milligrams per deciliter. That's the number we use here in the US. In Canada, I think you say 60 grams per liter. So if it's above that, we'll do it even if a patient has no symptoms. But in general, you treat patients because they're symptomatic. You know, they're becoming more anemic, or their, you know, platelet count is going down, and they're, you know, more at risk of bleeding. They've developed, you know, symptoms like the ones I spoke about earlier. They have neuropathy, or they've got those cryoglobulins that I showed you that are, you know, profound. We like to treat patients because they're symptomatic, not that we necessarily treat them because of, you know, the IgM per se. Now, if somebody comes in and, you know, a year ago, you know, their IgM was, you know, 1,000, 6 months later it was 2,000, now they're 4,000. If it's really going up in a very exponential way, we're not going to let that patient fall off the cliff before we extend a helping hand. Usually when numbers go up like that, the blood counts start coming down. So you have indices that are telling you that it's not just about the IgM going up, but other things are happening to the patient and you need to be paying attention.
Okay, thank you. Ray had heard about the patient WM risk calculator that Dana Farbus published. Can you comment on how this calculator works and how you recommend it be used by patients and their doctors?
Yeah, I really don't want to get into prognostics, tonight, because there's a lot of detail involved and there's different competing, indices that are out there. I don't want to say one system is better than the other, but when we look at risk of a patient, survival-wise, there are a number of factors that generally go into consideration. These are, for the most part, important, not for making treatment decisions, because we've never validated any one of these prognostic systems for making treatment decisions other than MYD88 and CXCR4. We tend to use them as reporters for trials. So when a doctor sees a patient, they know if somebody who has high risk disease is going to do just as well on a particular therapy. And the BTK inhibitors are an important change in the way patients are doing, because even patients that have high risk factors, advanced age, high IgM, decreased platelet count, decreased, hematocrit. These are all factors, beta-2 microglobulin, elevated. These are all things that are normally synonymous with, worse outcome. The BTK inhibitors seem to overcome many of these, high risk factors.
Okay, thank you. And she wanted to also know if how you can clarify how beta-2 microglobulin factor differs from beta-2 globulin factor.
Okay, so beta-2 microglobulin is what we use from a prognostic point of view. I think the question that is being asked is whether the gamma globulin region of the, when you do an immunoelectrophoresis, there are various regions. There's the alpha, beta, and gamma. Gamma is where the IgM lies. But there's this other region called the beta region, and there are other proteins in the blood that are found there. So, but if you're looking at a prognostic factor, it's the beta-2, B2M, beta-2 microglobulin. Usually in studies, if it's above 3 or 3.5, it's an adverse, prognostic marker.
Okay, thank you. We're having tons of questions, Dr. Treon.
I can tell.
Is nerve pain or muscle spasm a possible side effect from taking ibrutinib?
Yes, you can have muscle aches and pains, joint pains that can go with ibrutinib. And sometimes reducing the dose, if will make a difference.
Okay, next question. I'm having trouble. Oh, there we go. If I'm receiving Rituximab during this pandemic, does this put me at more risk? Will this year's influenza vaccine give me any protection? I've had WM for a long time and have most recently had Rituximab infusions in August in the first week of September.
Yeah, no, it's a wonderful question to which we have limited insight. There was an interesting study done by my colleague Ron Levy at Stanford many years ago. Ron actually was the inventor of Rituxan, and in fact, the founder of the company IDEC. And in order to enable the trials to go forward, he actually sold all his interests in IDEC to be able to help that trial move forward. So we owe so much to Ron, but an absolutely brilliant immunologist. But he treated mice with Rituxan, and he immunized them to see if they would react to, the immunization. And in fact, if the mice had been exposed to Rituxan, they didn't mount the antibody response, to the immunization. Now, immunity is very complicated, and thankfully it's redundant. We have many different types of cells that when you do immunize somebody, will mount our immune response. There are the B cells, which Rituxan affects, and Waldenstrom is a B cell. And then there are T cells that also go after various pathogens, and their mechanisms of action are very, very different. There's also macrophages, which have yet another system that goes after infection. And so it's this redundancy that helps protect patients, even if they get Rituxan, from getting these recurring infections. But as many of you know, if you've had too much Rituxan or other drugs, sometimes you can end up with sinus and bronchial infections and you need IVIG. So the long and short of it is some of the data would suggest that Rituxan does in fact attenuate the response to immunizations. There have been clinical studies that have looked at this with mixed results. Also with ibrutinib, the NIH did a very nice study looking at influenza response with patients with CLL on ibrutinib. They found that in fact, 70% of patients mounted a response, an antibody response. But they were only looking at the B cells. They weren't looking at the T cells, which would be also yet another system for going after viral infections. So there's redundancy, thankfully, built in the system. But I would say that these drugs do have some impact that needs further clarity.
Thank you. Charles wants to know, many WM patients have weak immune system. Is this an advantage for a patient that contracts the COVID virus?
Well, I don't think so. I mean, I wouldn't say you should be proud of having a weak immune system. And the cells that actually make the inflammatory proteins are those macrophages and monocytes, and those are not as impacted by the drugs that we typically use to treat Waldenstrom's. So those cells will still be there and still be firing off, their proteins, their inflammatory proteins.
Thank you. Betty wants to know about the flu vaccine in the high dosage. What you recommend and what's the difference between the high dose and the regular flu vaccine?
Yeah, well, this was actually studied by Andy Brannigan, who is now a part of our Waldenstrom group, and he published a study, showing in fact that it was a patient. The study population was cancer patients, but he did show that having the high dose flu vaccine resulted in stronger titers, and more importantly, in longer lasting immunity. So that tends to be the recommendation these days, unless there's a contraindication that your doctor may come up with. That's usually what we do.
Good. In BTR therapy, would giving the bendamustine several days before giving the Rituxan lower the amplitude of the Rituxin flare?
So I'm a little confused, and it's from Charlie Schaefer. So Charlie, BDR is bortezomib dexrituxin. So I wonder if you meant bortezomib instead of bendamustine.
Dr. Treon, I meant bendamustine.
Okay. Yeah, it's a good question, Charlie. So normally the way bendamustine is given is you get it 2 days in a row and you get the Rituxan on the second day. Our experience is that bendamustine is not a very good blocker of Rituxan. So, in somebody who might have an elevated IgM, usually above 4,000, we'll give the bendamustine alone for the first cycle or two and then add it in, during the third and fourth cycles. So if there's any concern about the patient having a high IgM and being at risk of a hyperviscosity in response to the Rituxan, we'll usually omit it as opposed to delay it. The drugs that actually affect the flare in a good way are bortezomib does. It blocks the flare. It's not a very potent blocker, but it can block the flare. And ibrutinib is by far the best. There are drugs, on the other hand, that do the opposite. You know, you don't see them now because we've kind of largely abandoned them, but thalidomide and Revlimid that we used to use, you know, early on actually would potentiate the flare. And we had people flaring for 6 months. So that's why we don't use those drugs now with Rituxan. But bendamustine tends to have, you know, not much of an effect on the flare. So if you're going to flare, you're going to flare.
Thank you. There's a question, and I don't know the answer, but I think it's not. Is anyone in Canada getting zanubrutinib? I don't believe it's been approved.
Yeah, well, I don't know the answer definitively. You know, this is still in clinical trials, and in the US, it's part of open access. So I don't know. We've been putting patients on zanubrutinib as part of the open access program. The patients are not charged for the zanubrutinib as part of the open access. That will end once the drug becomes commercially available. I don't know if there's any sites that are in Canada as part of the open access. So one can look that up under clinicaltrials.gov, and you want to look under open access, you know. So there may be sites up in Canada. I just don't know because it's open at many different sites, and I just don't know if there's any Canadian sites.
When we talk to Dr. Berenstein, I think he'll be able to answer that question.
Yeah, yeah. But it's on clinicaltrials.gov. So, you know, if anybody wants to peruse over there, you'll find your answer because it is a formal trial, but it's expanded access is what it's known as.
For people, Patricia wants to know if for people who are on ibrutinib but did not do well to the side effect, can they be on those trials you mentioned?
Yeah, it's a great question. The answer is no. So these trials are really meant to assess people who have not seen a BTK inhibitor. We do migrate patients over. Again, it's based on availability, but if we do see that patients aren't tolerating ibrutinib, we'll migrate them over either to acalabrutinib or zanubrutinib, depending on the toxicity. But it depends on whether or not the insurer will cover it or if it's expanded access and we can leverage it.
Thank you. David wants to know, can CXCR4 mutation be determined from peripheral blood?
Yeah, that's a really good and complicated question. So CXCR4 mutations come in two different flavors. There are these mutations called nonsense. So I'm going to teach you something tonight that, some verbiage here. So nonsense is when part of the molecule gets cleaved off. And then there are frame shifts. Frame shifts are when you scramble the protein. It's important to know that the people that come in with these nonsense mutations, the ones that have sky-high IgM levels and have symptomatic hyperviscosity, they also are the folks that will be more resistant to ibrutinib than the frame shift. So knowing the type of CXCR4 mutation is important. Nonsense ones we can more easily detect in the peripheral blood than we can the frame shift ones. Frame shifts just require a different handling. And we have done the studies looking at CXCR4 detection by peripheral blood. You can pick them up, but it's best done in somebody who's never seen therapy before. Now we're going to be publishing this very soon. We're going to be using a different technique called cell-free DNA analysis. This time we don't depend on cells in circulation. We actually scoop up the DNA from the blood itself. And then we look for these mutations, both MYD88 and CXCR4. The CXCR4 nonsense mutations, we can pick up very, very nicely. We can scoop them up right out of the blood. So I see going forward that this will become a much easier, hopefully cheaper way of being able to pick up these mutations without obligating the patient to a bone marrow biopsy.
Thank you. Jennifer wants to know do you have to have a CXCR4 or MDY88 tests? My doctor says I don't need it. I've been on Acalabrutinib for 6 years.
Well, okay, Jennifer, great question. You've been on it for 6 years, which is wonderful. That means I'm hoping it means it's working. So most likely you've got all the right genomics there, and kind of retrofitting in, the genomics into what seems like a great response probably isn't necessary at this time. Thank you that's a great question. I think it's something that, you're already a winner. So we don't need to go back and backdate everything to the initial genomics. But going forward, it would be good, if you ever require therapy again in the future. I bet a lot of the newer, therapies after ibrutinib, we'll still have to, kind of figure out what your mutation status is. And, there may be new drugs at that point, like CXCR4 inhibitors. So it would be important in that case to know if the CXCR4 mutation is present or not.
Thank you. Michael wants to know, what are the expectations for diminished neuropathy after completion of Rituxan maintenance and its lasting effects?
Yeah, great question, Michael. So look, the expectations when you treat somebody with IgM neuropathy depend a lot on how long the patient has had the neuropathy. So the longer you've had it, things are going to be different. The expectation then is you're trying to treat the patient to prevent the neuropathy from getting worse. If you treat somebody early in the course of their neuropathy, ideally within 2 years, there's also an expectation that you can reverse it. But after 2 years, our experience, and we have done this study, is that a lot of the nerve damage becomes irreversible. And so the purpose of treating at that point is to stop things from getting worse or slow down things from getting worse with Rituxan.
Dr. Gobiel? Ron wants to know, I missed Dr. Gobiel's presentation on the research going on and may lead to a cure with the precursor group, watch and wait group. Do you have an update?
Yeah, so Dr. Grobriel's focus these days is on precursor conditions. So IgM-MGUS, monoclonal gammopathy of unknown significance for Waldenstrom, as well as all the different MGUSs that lead to myeloma. Most of our efforts today are, still collecting and trying to understand the genomics to better understand what it is that's triggering the conversion from MGUS to Waldenstrom. In the myeloma sphere, her efforts have been to try to actually start therapy earlier before the disease, progresses. And drugs like daratumumab are part of that, effort, the monoclonal antibody daratumumab. We have done a trial with daratumumab that we just published, or just actually will be published, but it's been accepted to the Journal of Blood Advances. We did not see any activity. To our surprise, we thought daratumumab would be also very active, like Rituxan is, but we didn't see any activity in Waldenstrom. So we don't see that really as being beneficial to stop the progression of the precursor condition to Waldenstrom, since even in Waldenstrom we didn't see any activity.
Thank you. Jimmy wants to know, can a test for gene mutation be accurate or indeed possible after a full course of Mustine and Rituximab therapy?
Yeah, no, great question, Jimmy. We try to get the mutations done when a patient is first diagnosed or before therapy, because the chances of detecting are better. But it really comes down to how much disease is there. I mean, if you've wiped out the disease with bendamustine and Rituxan and have very little disease, it may be harder to detect the mutations, particularly CXCR4. It's much harder to detect CXCR4 as opposed to MYD88. But it depends a lot on how much disease is left behind. If there's still appreciable disease, the chances are pretty good.
Dr. Treon, thank you so much. You've answered all their questions. You've done it fairly succinctly. That's pretty good. And it's just been a pleasure having you tonight. So
I have to interrupt, Paul. Sorry. There's one question that was sent to me privately. I don't know why they weren't able to send it on their iPad to everyone, but it was, what are your thoughts on flying? On flying in November with a mask, face protector, wipes, etc. Your friend, Dr. Sanchar Awala, says it's okay with care. What do you think?
Complicated question, to answer. There are studies that have shown, transmission in airplanes. This was at the height of the pandemic when no one was wearing a mask. Presumably the mask wearing will have decreased the risk. What worries me a lot is now that I see these airplanes, you would think people are getting spaced out. And in fact, they're as packed as ever. So that does lend me a lot of concern that if you are, packed in that very tight space, you're not social distancing. So I guess I still have my reservations about, travel, and no one, I think, I used to cross the Atlantic sometimes 4 times a week, going and giving lectures in Europe and coming back. I was back and forth to Asia so many times, within a month. Even without the pandemic, your chances of coming off a long plane ride and having a cold were very good. And studies have documented that, that looking at how people did within 2 weeks of long flights, over 3 hours, your chances of ending up with a cold were much higher than somebody who hadn't been on an airplane. So I think, we need to keep in mind that even at baseline, patients are at, or people are at higher risk of contracting an infection. And, in the COVID-19 setting, I just don't know if a mask, especially in that kind of very tight, situation. I've seen these planes now. I mean, you see people are just packed like sardines still. I guess I would still have some concern, particularly for somebody who might be potentially immunocompromised. So that's as far as I'd like to go on my concerns and recommendations. And I think it was a good one to help share.
Do you, I did ask the question about vaccines earlier, but do you recommend any other vaccines that Waldenstrom patients should have in protection against COVID or during this time of COVID?
Yeah, well, the good news is the trials are advancing very nicely. The Moderna as well as the Pfizer vaccines, which are mRNA based, these are actually easy to make, these types of vaccines. They don't require that protein be made, which is much more harder. These trials have done exceedingly well. The data is supposed to be reviewed in the next 2 to 3 weeks' time. And at least here in the United States, there's a good chance that there may be an emergency use authorization, probably for the Pfizer vaccine first, either late November or early December. Now, all that means is that the drug or the vaccine could be potentially available now for distribution, but it's going to take some time. I want to make maybe 1 or 2 comments about the vaccine, because I think it's important for people to keep in mind that even if you get vaccinated, and the vaccine strategy right now is you get 2 vaccines 4 weeks apart, it still may be another month after the second vaccine before you get sufficient immunity. One should also keep in mind that just because you're immunized, it doesn't mean that you may not distribute the virus to somebody else. You might get it. It may not cause you harm or much harm, but you might get still infected and potentially give it to somebody else. So it's going to be very important, for patients to still keep their safeguard, for their families to keep their safeguard until, our population as a whole has become vaccinated. And then this is when we develop what we call herd immunity, that enough of us are vaccinated that even the few that may not be, there's enough protection now in the general community to help decrease that risk to one particular individual.
Paul, were there any more questions?
Great. Paul, I think you're on mute. Whatever you said sounded great, but we didn't hear you.
No, you've done a great job and you've answered everything that we were asked. So
Awesome, awesome. Well, I want to wish everybody a wonderful evening, and thank you once again for all the support you and Waldenstrom Foundation in Canada have given to the research cause, and it's always wonderful to be with all of you. Take good care and stay safe and stay well.
thank you so much.
Dr. Treon.
You've been wonderful, Steve.
Thank you. Good night, everyone.
Thank you from Florida, Dr. Treon.
Bye-bye. Thank you.
Thank you, Paul, and thank you, Betty.
Bye-bye, everyone.
Before everyone goes, I think because of the number of people and the time, I think we will forego our sharing until the next meeting. What do you think, Paul?
Yeah, absolutely. I think that's enough for tonight. We've had a lot come at us.
So the next meeting again is December 2nd, Wednesday night at 7 o'clock. Paul will be putting it in a newsletter with a link, and we look forward to seeing you all then.
John's birthday.
Thanks, Betty.
Thank you. Have a wonderful evening. Bye-bye.
Thank you all.
Thank you, Paul.
Thanks, Paul.
Thank you, Paul. Thank you, Betty.
Thanks, Paul.
Good night.
Bye.
Good night.